In this video, I will go over the physiology of the adrenal glands, discuss the function of different hormones produced by this gland, and then later on discuss the pathophysiology of different disorders. So if we have the kidneys, then on top of the kidneys we have the adrenal gland, and it's covered by a capsule. The next layer after that is called the adrenal cortex, which is made of 3 layers called zona glomerulosa, zona fasciculata, and then zona reticularis. And all these layers are derived from the mesoderm. And then the innermost layer is called the adrenal medulla, as shown right here, adrenal medulla, which is derived from the neural crest cells. So next, I would like to go over the function of different hormones that are produced by these parts of the adrenal gland. So here again we have another drawing of the adrenal gland. Here we have the adrenal medulla, which is derived from the neural crest cells, and its function is to produce catecholamines such as epinephrine and norepinephrine. Then we have the adrenal cortex, which is made of the zona glomerulosa, zona fasciculata, and then zona reticularis. So the mnemonic that you can use to memorize the layers from outside to inside is called GFR. And then one other mnemonic that you can use to remember what hormones are produced by each of them is to know that as you go deeper, it gets sweeter. So the outside layer produces the hormone that is responsible for absorption of salts. So the aldosterone, which regulates salts. And then the next one, cortisol, regulates sugar. So here we have the sugar. And then finally, androgen is a sex hormone. So the deeper we go, the sweeter it gets. First salt, then sugar, and then we have the sex. Now the secretion of aldosterone is regulated by the renin-angiotensin hormones, while the secretion of cortisol and androgen are regulated by the ACTH, which is secreted by the pituitary gland, and then ACTH itself is regulated by CRH, which is secreted by the hypothalamus. So next, I would like to go over the mechanism through which renin-angiotensin becomes active and acts on the aldosterone. So here, angiotensin is being produced by the liver, and then via the renin, angiotensin is converted to angiotensin 1. And then renin itself is produced by the juxtaglomerular apparatus, which is made of the juxtaglomerular cells, which is shown right here. So these blue cells are the juxtaglomerular cells that are covering the afferent arteriole. And it induces secretion of renin when there is decreased blood pressure. So by being located in the afferent arteriole, it would be able to detect low blood pressure. And then the other structural cells called macula densa are located on the distal convoluted tubules, shown right here in gray. And these cells will detect low sodium concentration. And then so if there is low sodium concentration and low blood pressure, then there would be increased secretion of the renin by the juxtaglomerular cells. So once renin is secreted, it converts angiotensin into angiotensin 1. And then angiotensin 1 will be converted to angiotensin 2 via the angiotensin converting enzyme, also known as ACE. And ACE is secreted in the lungs and in the kidneys. And then finally, angiotensin 2 will cause vasoconstriction. It will induce the secretion of the aldosterone. And then finally, it would induce the secretion of antidiuretic hormone, also known as vasopressin. Now I would like to remind you that medications that inhibit ACE are called ACE inhibitors, and examples of ACE inhibitors include lisinopril or captopril. And these medications are used to control blood pressure. Now, however, since the ACE will inhibit bradykinin, once you prescribe ACE inhibitors for a patient, there would be increased concentration of bradykinin in these patients. So therefore, one of the side effects of these medications is due to the increased production of the bradykinin. These patients will present with a dry cough and angioedema. And if you want to avoid these side effects, then you can use an alternative medications, which is called angiotensin 2 inhibitors, and an example of it would be losartan. So you can prescribe losartan if the patient cannot tolerate the cough and angioedema, and this medication works by directly inhibiting the angiotensin 2. In any case, next I would like to explain the mechanism of function of the aldosterone. So aldosterone will work on the principal cells and the intercalated cells in the kidneys. So first it will open the apical channels and will induce the secretion of potassium into the lumen of the renal tubules. while it induces the absorption of the sodium. And then it works on the sodium-potassium channel to further induce the absorption of sodium while it causes secretion of the potassium. So therefore, it would increase sodium concentration while it decreases the potassium concentration. Finally, aldosterone works on the intercalated cells to induce the secretion of hydrogen and increase the production of HCO3 negative. Now later on I will explain how over-secretion of the aldosterone will cause the metabolic alkalosis because of the increased secretion of the hydrogen while there is increased production of HCO3, and it will also cause hypertension because of the increased resorption of the sodium, and it will cause weakness due to hypokalemia, and I will discuss that later with you. So back to the table. So that was for the function of the aldosterone. Then we have the cortisol, which is produced by the zona fasciculata and is regulated by the ACTH. And cortisol has many functions such as suppressing the immune system. It can cause osteoporosis, it can cause hypertension, it can increase the sugars of the blood, and so on. So it has many different functions, which I will cover later on while discussing the Cushing's syndrome. So first disorder I will go over is called the Addison's disease, and Addison's disease is the primary adrenal insufficiency. So the adrenal gland is not able to produce enough cortisol or enough aldosterone. The other condition that can cause adrenal insufficiency is long-term use of the steroids, and that would provide a negative feedback. It would suppress the excretion of ACTH, as a consequence of which there would be again decreased level of cortisol and aldosterone. And I will go over the difference between secondary adrenal insufficiency and primary adrenal insufficiency in a minute. But first I would like to explain that decreased cortisol in these patients will cause hypoglycemia, it will cause hypotension, and then it will cause hyperpigmentation, because since there is not enough hormone produced, there would be a positive feedback to increase the production of the ACTH. And ACTH is derived from the pro-opiomelanocortin, which will produce the ACTH, it will produce the beta endorphin, and it will also produce the melanocyte stimulating hormone. So in these patients that have primary adrenal insufficiency, since there is not enough hormone production, there would be a positive feedback to increase ACTH. Once ACTH is produced, there would be also melanocyte stimulating hormone that is produced. So these patients will become hyperpigmented because of the increased production of MSH. In patients that have secondary adrenal insufficiency, however, since there is decreased production of ACTH, they would still present with hypoglycemia and hypotension due to decreased cortisol, but then there won't be any increase in the production of MSH, so they would not present with hyperpigmentation. So one big difference between primary adrenal insufficiency and secondary adrenal is the lack of hyperpigmentation in secondary adrenal insufficiency. And then finally, low aldosterone level will cause low levels of salts, as a consequence of which these patients present with hypotension, and then there would be increased levels of potassium. And for the treatment of these patients, you can provide prednisone to cover for the lack of cortisol, and then you can provide with fludrocortisone to cover for the lack of mineralocorticoids. And the way I memorize it is that flood reminds me of a flood, so you'll flood your patients with a sea water which has a lot of salt. So this way you can compensate for hypotension in patients with adrenal insufficiency. The next condition is the hyperaldosteronism, and there are two causes of hyperaldosteronism. One, increased secretion of the aldosterone by the adrenal gland itself, or secondary hyperaldosteronism, where there is increased renin production, which can be caused due to the renal artery stenosis. And since there is a renal artery stenosis, there is decreased blood pressure in the afferent renal arteriole, as a result of which the juxtaglomerular cells will increase the renin production, and renin will act on the angiotensin, which will later on increase the production of aldosterone. So in these patients, due to the increased renin production, they would also have increased aldosterone production. In primary hyperaldosteronism, it's the adrenal gland that is producing the aldosterone. However, since there is a negative feedback on renin, then these patients will have low levels of renin. So the other name for primary hyperaldosteronism is called Glands syndrome, which is usually due to the adrenal adenoma, or it could be due to the adrenal hyperplasia. And then you may recall that I explained the function of the aldosterone with you. It increases the levels of salt, so these patients will present with hypertension. It will decrease the levels of potassium, so these patients can present with hypokalemia and weakness. And then it increases the secretion of the H+, so these patients can also present with metabolic alkalosis. And one way that you can treat these patients is the surgical resection of the adenoma, or in patients that have hyperplasia, you can treat them with the spironolactone, which is an aldosterone antagonist. So the hyperplasia is treated with spironolactone, while adenoma is treated by the surgical resection. The next disorder is the Cushing syndrome, and there are different etiologies to the development of Cushing syndrome, all of which are associated with increased levels of serum cortisol. So the most common cause of Cushing syndrome is exogenous administration of steroids. So the patient is administering too much steroids, as a consequence of which they develop Cushing syndrome. The second most common cause is called Cushing's disease, which is from a pituitary adenoma that produces too much ACTH, and thus it causes increased production of the cortisol. The other cause is the presence of the adrenal adenoma or carcinoma, which will directly increase the production of cortisol. And then finally, we have ectopic tumor that will cause ACTH secretion. So ACTH secreting ectopic tumor. And small cell carcinoma of a lung is an important example of the ACTH secreting ectopic tumor. Now, with the exogenous administration of the cortisol, there is increased level of cortisol, which provides a negative feedback to the pituitary gland. So these patients will have low levels of ACTH. With the Cushing disease, there is increased level of ACTH. With ACTH secreting ectopic tumor, also there is an increased level of ACTH. In patients with adrenal adenoma, there is increased level of cortisol production, which will again act on the pituitary gland and decrease the level of ACTH. So with all of these conditions, there is increased cortisol, but some of them are associated with decreased ACTH, while some are associated with increased level of ACTH. And one diagnostic tool that you can use to differentiate Cushing disease from the other ones is to administer high dose of dexamethasone. And high dose of dexamethasone is capable of suppressing the cortisol levels in the serum of patients with Cushing disease, but not in patients with adrenal adenoma or ACTH secreting tumor. So just keep that in mind, that a high dose of dexamethasone is capable of decreasing level of cortisol in patients with Cushing disease, which is caused by the pituitary adenoma that secretes excess ACTH. Now, the presentations of patients with Cushing syndrome include the moon faces, so they would have like a moon faces, and they would have a buffalo hump, they will have central obesity, and then finally they will have the stria, which is shown right here. Other findings include acne, easy bruising, diabetes because they have too much cortisol, and then finally muscle wasting. And then you can treat these patients, those who are taking exogenous steroids, you have to taper the glucocorticoids, and that would be the treatment for them. Patients with Cushing disease, since there is a pituitary adenoma, you have to use the transsphenoidal ablation of the pituitary adenoma. And then finally, for patients that have the adrenal adenoma, you will have to resect the adrenal adenoma. The next condition is the pheochromocytoma, and this pheochromocytoma is the most common tumor of the adrenal medulla in the adults. And due to the increased production of the catecholamines, these patients generally present with the hypertension, sweating, anxiety, and finally palpitations. So these symptoms, sweating, anxiety, palpitations, they remind me of the panic attack. So patients with panic attack are actually having increased levels of the epinephrine before the attacks. So patients with pheochromocytoma also have increased level of epinephrine. So it's not surprising that they would present with similar symptoms like sweating, anxiety, and palpitation, as well as hypertension. Now, the course of the pheochromocytoma is relapse and remitting. So these patients will have these symptoms, resolved, then we'll have them again. So it keeps on going back and forth. It's not like they present with sweating all the time. No, it's relapse and remitting. And then the way you can screen for these patients is to look for the urine breakdown products for catecholamines, which include the vinyl mandelic acid as well as the metanephrine. And one other way to detect the pheochromocytoma is directly to measure the levels of catecholamines in the serum. Now, the treatment for pheochromocytoma is resection. But if you right away resect the adenoma in these patients, what happens is that their blood pressure may drop to a critical level. So it may cause the hypotensive crisis. Now, to avoid that, what you will have to do is that about 2 weeks before the surgical resection, you have to supply these patients with the phenoxybenzamine. And this is an alpha antagonist. So this way you will prepare the patients for what is to come next. So by providing them with an alpha antagonist, body will increase the volume of blood. And once you resect the tumor in these patients, despite the blood pressure drops, since there has already been an increase in the blood volume, these patients will not develop hypotensive crisis because you've already prepared them for what was to come next. So just keep that in mind. For pheochromocytoma, you will have to treat these patients with the phenoxybenzamine before resecting the tumor. And then the other condition regarding adrenal medulla that I would like to discuss with you is called neuroblastoma. And this is the most common tumor of the adrenal medulla in children. And unlike the pheochromocytoma, these patients do not present with hypertension. Now, neuroblastoma is usually associated with overexpression of the N-MYC gene and is malignant. So while pheochromocytoma is usually benign, neuroblastoma is malignant. And then you can detect neuroblastoma by detecting the homovanillic acid as a breakdown product of dopamine. So for the pheochromocytoma, we were detecting the EMA and metanephrine, while with neuroblastoma, we are detecting the HVA or homovanillic acid in these patients. Next, I would like to go over the congenital adrenal hyperplasia, and then that's the last topic that I will discuss for this video. So you should know that zonal glomerulosa will produce the aldosterone with the help of the 11-beta and 21-hydroxylase enzyme. Zona fasciculata will do that by 11-beta, 21, and 17-alpha hydroxylase, while zona reticularis will produce the androgen by 17-alpha hydroxylase. So different enzymes are required for the production of the aldosterone, cortisol, and androgen. And the way I memorize it is that I would list them from outside to inside. So salt, sugar, and sex, G, F, R, so aldosterone, cortisol, and androgen. And if you can memorize just how to put these enzymes in this order, then it would be so easy to be familiar with disorders of the adrenal congenital hyperplasia. So 17 here, 21 here, and then 11 here. And there you go. You're done with knowing what enzymes are required for the production of different hormones. 17, 21, and 11 hydroxylase will produce cortisol. 17 will produce androgen, while 21 and 11 will produce aldosterone. Now, if there is a deficiency of the 17 hydroxylase enzyme, then there would be decreased level of cortisol as well as decreased level of androgen. So then there would be increased production of the aldosterone instead, since none of these are being produced by the adrenal gland. So therefore, these patients, since there is increased aldosterone, there would be increased levels of sodium, and thus they present with hypertension. There would be decreased level of potassium, and thus these patients will present with weakness. And then finally, since there is not enough androgen produced, males will have ambiguous genitalia. 21 hydroxylase deficiency will cause lack of the cortisol and lack of the aldosterone, but then there would be increased androgen production. So since there is increased androgen, these patients will present with masculinization. But again, since there is low level of cortisol and low level of aldosterone, there would be low salt, and thus these patients present with hypotension, and then there would be increased potassium. Now, one way to detect this 21 hydroxylase deficiency is to look for the level of 17 hydroxy progesterone in the serum, and that's one diagnostic tool for 21 hydroxylase deficiency. And then the next condition is the lack of the 11 beta hydroxylase. So it's a little crowded here, so I'm going to redraw it. So here we have aldosterone, cortisol, and androgen. We had 17, 17, 21, 21, and 11, 11. So if there is lack of the 11 beta hydroxylase enzyme, there would be no cortisol and no aldosterone in these patients. However, there would be an increased level of 11 deoxycorticosterone in these patients, and this 11 deoxycorticosterone is a mineralocorticoid, so it acts similar to aldosterone. So therefore, even though there is decreased level of aldosterone in these patients present with the increased level of salts, which causes hypertension, and they present with hypokalemia because 11 deoxycortisone acts as a mineralocorticoid. And that concludes our discussion of the disorders of the adrenal glands.